Hello, I'm Mabel Jong. Welcome back. We're day one here at the World Healthcare Congress. And in the studio, we have Wayne Turnage, who's Director, DC Department of Healthcare. Wayne, it is so great to see you.
Great to be here.
Yeah, and I just wanted to get an update from you. Do you feel that the district has really managed the issue of healthcare coverage?
Well, I think we've mastered the issue. If you look at the data on the uninsured in Washington, D.C., you will find that the district insures roughly 96% of D.C. residents. We have a Medicaid program and something called the Local Alliance program that together provide coverage to over 40% of the district residents. And probably when you do the numbers on the Medicaid side, probably about 96 to 97% of all people who are eligible for the program are actually receiving services. So I think we have mastered the coverage issue in a way that no other state has in the country.
Well, it certainly sounds like it. So what do you see as the next big challenge?
Well, the next big challenge is to ensure that people, now that they have coverage, to ensure they are using the system appropriately and not unnecessarily driving up healthcare costs. When you have that many people who are insured, there's always a concern that if they have not had insurance over time, that they could use the system in a way that's inappropriate. And we have seen data that does suggest that we have a problem with the way people are accessing care, even though they have coverage. We know that, for example, 70% of all the visits, roughly, to the hospital for people who are in the Medicaid program and in managed care actually are for non-emergency visits. We see a high rate of avoidable hospital admissions, and we also see a very high rate of readmissions to the hospital after 30 days of the initial admission.
Okay, so is that going back to one of the challenges that we used to see where people were using the emergency room as their primary care visit, if you will?
Without a doubt, and what makes this so difficult to explain is the fact that in the past people used the hospital as their primary care physician because they did not have coverage. They had no access to specialty care, and so they basically waited till they got sick and they went to the emergency room. Now we have a population that is largely covered. There's no reason to wait until you're sick to go to the doctor, and the hope is that they will begin to access primary care more appropriately to receive some of the preventive measures that can eliminate the need for future hospitalizations and also create the proper gateway to the system. You don't go to the highest cost end of the system first. You go to your primary care doc and let them do the necessary work to evaluate and decide, or help you decide how deep in the system you need to go for care.
Okay, it sounds like, so that's an ongoing challenge for your office to get that message out there.
Very much so.
Okay, what about people who are not in managed care? What are some of the challenges they pose for your office?
Actually, that population poses some of our biggest challenges. We know that our managed care plans cover roughly 70% of our Medicaid and Alliance beneficiaries, and that leaves about 25% of the persons who have health care coverage, but they are not in the organized network of care. These folks are typically persons who are disabled, who would be eligible for probably federal disability if their incomes were not too high. They're also, in the district, we allow people who have HIV to opt out of managed care if they choose. We don't require kids who are in foster care to be in managed care. And so you have a smaller population that we have found through data analysis that's generating about 75% of the cost of the system. So you have about 25% of the people in the Medicaid program generating about 75% of the cost of a $3 billion program. So it's a very small percentage. And we went a step further and we tried to determine, well, is there a subgroup in this population of fee-for-service beneficiaries, is how we label them, that cost us more. And we found that a small slice of that 25%, 17% actually, account for 75% of the total cost of the fee-for-service program. So it is a group that is largely unmanaged. They are typically sicker than the managed population. They go to the hospital more often. When they go, they stay longer. And when you look at just their prescriptions, we did an analysis and found that the high-cost beneficiaries in fee-for-service get on average 58 unique prescriptions a year. That is a enormously high number that speaks, in my belief, to a problem of unmanaged care.
Okay, okay. And so how is the office tackling that? How is the district going to?
We are
that?
putting in place several initiatives. We are trying to build, in partnership with the federal government, build what we call health homes. And these are plans to hire sort of a team of physicians, caseworkers, who will be assigned a number of these persons who are in the fee-for-service program, and they will be responsible for managing and coordinating their care, and we will provide incentives for them to make sure that the care is provided appropriately and hopefully provided in a way that will produce more favorable patient outcomes.
Okay, and thank you so much, Wayne.
Thank you for having me.
And I'm Mabel Jong. Thanks for watching.